Now, starting from the first thing, what are the common causes of infertility? The common causes of infertility include endometriosis, right? Tubal blockage, endometriosis, ovulation disorders, cervical factors and luteal phase abnormalities constitute less of the causes. What is cervical factors? Cervical factors like the cervical mucosa, the cervical secretions are hostile to the sperm penetration and all those may create problem. And luteal phase abnormalities like the luteinized, the short luteal phase, or they don't even know the hypothesis for most of them that what is the reason that for the luteal phase abnormalities. And then they say everything may be normal, husband may also be normal, but there may be unexplained infertility in about 5 to 10% cases. So as such, infertility is not a very simple thing to deal with. It is a complicated thing which involves everything: hormonal studies, ultrasound studies, history taking, counseling, everything is included in that. We will talk about the ultrasound part. Where all would we need ultrasound when we are dealing with a patient of infertility? We will need it from beginning till the end, right? So the first scan I told you is an initial pelvic scan that we do with TVS. What is the purpose of doing this initial pelvic scan? Anytime the patient comes to me, I will do a routine scan with TVS. We want to see the basic things. No, how is the uterine contour? What is the uterine shape? Is the uterus normal? Are the ovaries normal? Do I find any masses? Do I find any endometriotic cyst? Any polyp? Any myoma? All these things, right? Myomas usually don't cause infertility until and unless they are submucosal or they are multiple. If they are submucosal, then obviously we understand because they will occupy the cavity, and if they are multiple, then the problem is that blood supply to the endometrium gets hampered because of these multiple myomas, and as a result the endometrium may not be able to hold the conceptus for a long time. So these are the things that you may see on a routine initial pelvic scan. You may rule out uterine anomalies, may also be there. All these things you will rule out. Then the second step where we use ultrasound after this is for follicular monitoring or ovulation study, and to see the growth of the follicle. Then obviously when we do follicular monitoring, simultaneously we also assess the endometrium. So endometrial assessment again forms a part. Then assessment of tubal patency. Yes, the conventional method is HSG, but now we are replacing it gradually with sonosalpingography, right? Which is much easier and much safer, and it is much like you can say less painful also for the patient. And then last is obviously when we do AIs, when we do ART I should say, when we do the artificial reproductive techniques like IVF, guided follicular aspiration, oocyte retrievals, then when implanting the embryo, all those things we will be doing under ultrasound guidance, right?